Learning community. My name is Lydia Franco, and I'm part of your CTAC resource team. And today we're going to be covering part 2 of using anxiety and the MAP system with your clients. So using a MAP system with clients who have anxiety. So this is a continuation of the first webinar that we did last month, where we started introducing the different types of anxiety that we'll be covering in this quarter. We also talked a little bit about the practice elements, getting started with your dashboard, using the treatment planner, and complex cases. So this is a continuation of part 1. If you did not get to see the first webinar, I highly recommend that you go to our CTAC resource page for the PEDS learning community and take a look at that webinar recording or video as well, or at least look at those slides. Just some quick housekeeping before Julie gets started. Just a reminder, make sure that you're listening primarily through the phone. At one point, we're going to ask you to use the chat box, and the chat box is the the right side of your screen. There's a panel, and on the bottom it says chat. Underneath there's a blank box, and you would type in your responses there, as well as if you have any questions. As Julie's going through the different slides and topics, if you have any questions, you can type them in there. And make sure you click send to all panelists. There's a little drop down where you can pick who you want to send your message to. So thank you again for joining our webinar today. We have Julie Gutowski again, Managing Director of Clinical Operations at Spectrum Human Services and also part of our CTAC resource team. And she will get started now covering part 2 of our anxiety webinar. At the end of this webinar, I'm also going to cover sort of next steps, both our in-person meeting in November as well as our group check-in call. Thank you, Julie.
Thank you, and welcome to the webinar, Anxiety Webinar 2. And I just wanted to remind everybody that the slides and recording will be available on the CTAC website of today's webinar and also for the past webinars that we have done. There also is going to be some resources that we're going to post on the CTAC website. And sorry, I guess I sound a little staticky. If you could tell me, sorry, if you can hear me better now, because it may just be my phone connection. Now I'll have to call back on a different phone. Okay, great. Thank you. And so, okay. Hopefully you can hear me now, and I just wanted to remind everybody that the slides and recording are on the CTAC website, and we also have created and found some resources that you could use as part of the PEDS program that we're hoping will be helpful for you. And so what I wanted to start with is a review. Where do you begin? And if you could let me know through the chat box if I'm staticky or if I'm loud enough, I'd appreciate. Okay, so where to begin? Realistically, when the client walks into your office, you're going to think about a few things right off the bat, regardless of who is coming in to your office. Okay? You need to think about the individual's safety and the urgency of the issue. You really want to focus on a problem that is paramount to the child, adolescent, or the family. Okay? Also, think about where you're likely to get an early win. What we want to do as part of engagement is to make sure that people understand and believe in treatment, and the easiest way to get people aligned with treatment and to believe in treatment is to help them right from the start, understand that you're listening to them, you respect what their hopes and their goals are, and you're going to actually be able to help them. And then realistically, you begin when you have the information to develop a plan. So in terms of safety and urgency, if you have somebody who's avoiding school and has missed 15 out of 18 days, you know what, guys? What I'm going to try to do is I'm going to put it on hold for 1 second. I'm going to try to call in with a different phone. That way you guys would be better able to hear me. Hold on a second, please.
My apologies. The phone line sounded actually pretty good just before we got on, so I'm not sure what's going on there. So hopefully when she goes on to a new phone line, it'll sound a little bit better. Thank you, everybody, for sending in and letting us know. Sometimes it also varies by telephone you're on, and some people could probably hear better while others can't. So while we're waiting for Julie to come online, just a quick reminder. So we will be posting, again, the recording of this webinar as well as the slides on the CTAC resource page. Julie's also going to show us lots of resources, handouts, worksheets, things like that that you'll be able to use with your clients. So we're going to also post all of those handouts and worksheets on the, we're also going to post those on the CTAC resource page. And if you have any difficulty accessing any of those materials, make sure to reach out to us, and we'd be happy to help you walk through some of those as well. Okay, so while we're still waiting for her to come up. Is that Julie? Okay, so while we're still waiting for Julie to come on, I also wanted to talk to you a little bit about our in-person meeting. So November 13th from 9:30 to 12:30, we're going to have our in-person meeting. So the 6-month mark, essentially, of when we started the learning community. We want to bring everybody back together to come visit us again. Upstate will also do an in-person meeting as well. And we wanted to kind of touch base with you and process kind of how things are going. And during that meeting, we're also going to talk a little bit more about using the MAT system for clients with anxiety and the use of exposure as well. So it's very important that when you get that announcement, those registration links, you really try to come to that in-person meeting so we really get some feedback from you on what the process is like, and also to help problem solve any challenges you may be having, as well as just hearing from each other and everybody else's experiences. So that registration information will be sent out probably in the next, if it hasn't been sent out already, in the next couple of days, and it's really important that everybody from your clinic attempt to participate. If for some reason you're not able to, just let us know so that we can keep track and then see if there's any additional resources or support we can give to you after the meeting if you're not able to attend. Okay. So just give us one more second as I try to check in with Julie.
Hello?
Julie?
Hi, it's Julie. Can you hear me better now?
Yes, we hear you perfectly now, I think.
Okay, let me try 2 things.
If people could just chat and let us know that you hear okay, that'd be helpful, and then we can move right along. And Julie,
okay.
I was just kind of talking to people about the in-person learning community meeting and the next steps while we were waiting.
Great. And now my computer is frozen.
Well, it sounds, I just wanted to take a minute and thank everybody for your patience, and it sounds like everybody's replying that you sound much better and you're much clearer. So thank you for doing that, and thank everybody for staying on hold.
Okay, well, hopefully the computer problems will be taken care of shortly. So if you could let me know so you can hear me okay, and if you're looking at your computer, are you at the slide that says review, deciding where to begin? If you could let me know that, that would be helpful. Okay, perfect. And what I wanted to do is I wanted to thank everybody for participating today, remind them that the slides and recordings are on the website, and also a lot of the resources that either were created for this webinar or realistically a lot of the resources were found online. Those are going to be listed as long as there's not a copyright attached to them on our website as well, in hopes that it'll help you utilize the PEACH system. And so to review, deciding where to begin, when the individual comes into your office, you need to decide, well, somebody's here, they have anxiety, what do I do next? The things you're going to look at in terms of trying to figure out a treatment plan and the initial treatment plan are you're going to think about safety, urgency, and really to focus on a problem that the family and also the child or adolescent really wants fixed. Where are you likely to get an early win? Obviously, with exposure, exposure is a very common practice element for children and adolescents with anxiety. However, you don't start at that practice element. Again, think about it as gradually building up to the exposure therapy that you'll be doing with the individual. And we have some tools or suggestions to help you stay on track, okay? If you use the treatment planner worksheet from day one and the practice-wide system on day one and throughout the treatment process, it will allow you to stay on track, okay? If you use the session planner, that's going to help assist you in making sure that the cows or the crisis of the week don't become the focus of every clinical session you have with the child or adolescent. And if you're using the dashboard and you're explaining it to your child or adolescent and the family or caregiver, they're going to feel more connected as part of the process. What I'm going to ask you guys to do next is, if you could, in the chat box, list some common anxiety-provoking situations that children and adolescents come into your clinic and they say, these kind of situations really cause me a lot of distress. So I'm going to give you a few minutes, and if you could chat in the chat box, if you could type in there, we would be able to look at some common anxiety-provoking situations. And why we're asking you to do this is, it'll help us figure out where we need to focus not only the clinical attention we're paying to the individual, but also some resources that we can either develop or find that will help you address those. And thank you, Melissa. It occurs that social situations are a pretty anxiety-provoking situation. Going to school, bullying, class visitations, family conflict, leaving caregivers, school physical appearance, being made fun of, bullying, overall bullying and being picked on are some of the big issues that we're seeing by kids. And I also wanted to share with you guys, I have one of my clinicians with me today. Her name's Sherry Crossett. She's an LMSW, and she's going to be participating and sharing her experiences and how she's going to be utilizing the PEACH program with her client. So thanks for chatting your common anxiety-provoking situations. A quick review of anxiety disorders. And again, in the first webinar on anxiety, we provided information about these diagnoses for you to review when you have a few minutes. You have your generalized anxiety disorder, you have your obsessive compulsive disorder, panic disorder, post-traumatic stress disorder right now in the DSM-IV-TR is listed as an anxiety disorder. When we move to the DSM-5, that changes a little bit. Separation anxiety, simple phobia, and social anxiety disorder or social phobia. And we just wanted to take a few minutes because we've given you two tools to use for the PEACH project, and one of them is the RCADS. And some people have asked me, well, how can the RCADS help? Why would I want to use the RCADS? If you use the full version of the RCADS, it can help assess for broad category anxiety disorders and really help you narrow down. I kind of think of it as a tree, and so I start out at the top of the big tree, and it is the widest at the top, and then the general narrowing. So if somebody comes in, they may get a diagnosis of anxiety disorder, NOS, and that way, as I spend more time and we're able to get more information from the child or the adolescent, we narrow it down, which helps us in terms of what are we going to do clinically to help this person. Okay? And RCADs can assist in monitoring progress throughout treatment. A lot of times when our client comes in, he or she doesn't see the progress that they've made. It's really going to help us stay on track. If the NARCAD score does not seem to be getting lower as the person is staying in treatment, what we would need to do is look at, is what we're doing effective? And what do we need to do differently? And so again, the RCADs, it's the Revised Child Anxiety and Depression Scales. You can use it for children between 6 and 18 years. There's a caregiver and a self-report for older children. And except when younger than grade 3, use the raw score. Other than that, it generates a T-score. We've given you a nice little version of the RCADs to use, okay? And I'm showing that. Oh, hold on, I forgot to share my desktop. Hold on one sec, I apologize. And so this is the RCADs version that we've given for you to use with your children and adolescents. It's pretty simple, and so if the child, the top one is for the parent or caregiver, and then the bottom is for the youth. Basically, it's pretty much the same exact questions. Whether the person worries about things, the answers are never, sometimes, often, or always, okay? And so depending, you add up the scores at the end. The higher score means a higher level of anxiety. And so we recommend that you do this at the beginning of treatment before you really start treatment, so you're able to measure right at the top. And then realistically, I would tie this into every treatment plan review so you know if you're making progress. And then if you use the full version of the RCADs, you can assess for the specific anxiety disorders such as social phobia, and we've listed the questions for you that will relate to social phobia. So you can look at social phobia, panic disorder, separation anxiety, generalized anxiety, and obsessive compulsive. Like we had said before, we're going to cover the post-traumatic stress disorder, not as a part of the anxiety quarter, but in and of its own self quarter. And so what I wanted to do is talk a little bit about creating and monitoring behavioral indicators. And I'm going to hand over the phone or microphone, if you will, to Sherry Crossett. As I said, she is a clinician at our outpatient mental health clinic in Warsaw, New York, and she is an LMSW, and she's going to speak briefly about how she's going to be using the system with a newer client that she has.
Hello. I have just recently started to work with a 12-year-old female who was actually seen once before I had met her by a clinician that was leaving. So the very first session, unfortunately, that clinician had to tell her that she was going to be transferred. So when I met with her, her mom was present, and they had talked about how she was actually anxious just to come back to the clinic, and so that there was actually anxiety for her to just come into the clinic. So mom did a lot of the talking, which at first I thought that was because of her anxiety of coming back to us. But she was referred by mom for some odd behaviors, as mom puts it. Within like the last 6 months, she has refused to sleep in her bedroom, which nothing has changed. There's not a new house, no new friends or school or anything. And she has worried about her grades and her friendships and just some normal teenage things. However, a little bit, the grades was a big thing for her, and the grades were good. She was in sports and had lots of homework, so for what she was going through and dealing with, she had really good grades. Mom spoke a lot about the grades, so I did kind of get the vibe, I guess I'll say, that maybe some of this, is mom's values as well. And because I've only met with her the one time, I still have not completed the whole intake. So what I did was just use engagement skills, obviously, with the both of them for the first time. And the next session, I do plan on using the scale, the RCADS that Julie had just showed you, with both mom and child. And then going from there, obviously, what I plan is to work, review them with the child too, and see if some of her anxiety might be different than what mom thinks it is. So from there, I will continue doing that every 90 days, also like Julie said, which is when we do our treatment plans, and see if the score has changed. And throughout the sessions, what I will do is give her a scale that she can measure the anxiety daily from 0 to 10 that she can bring back to sessions. Depending on that, and since she's brand new to me, that obviously the scale, my plan to work with that is to do some of the practice elements that Julie's going to show you on the next slide to, possibly, depending on what the results are, maybe exposure therapy or, it kind of depends on what the scale says. So that is my plan, and I'm hoping it works. Thank you very much. Here's Julie.
Thank you, Sherry. And what I wanted to do is I just wanted to take a minute and show the clinical dashboard related to Allison. And so here we have on 10-3, on 10-1, this is the first day she was seen, and we did not do the scales at that point. The next time she comes in, if she were coming in next week, we would add the date that she is coming in, and then we would put the score. For both the RCADS and also for the anxiety level that's rated weekly, okay? Then what we have done is she was seen on 10-1, and what Sherry had done is she had done engagement with caregiver and engagement with child as appropriate, because she's getting information and we want the child to come back and the parent to find some benefit in coming. So really those first few sessions you're gathering information in the assessment and you're working on engagement, okay? And then we'll go to the presentation results. And then it shows the score for the RCADS, and I just had put a 12 in there. Again, when she comes back, Allison comes back next session, we'll be doing the RCADS with her, so we'll get her score. And then you can see that the attending was done in engagement related to the first visit. So what happens if Mom and or Allison want to work on something else or want to measure something else other than the level of anxiety? Let's say that Allison doesn't want to go to school and she's only attending school 3 out of 5 days of the week, and it's a little bit concerning because we're only a month in and she's already missed 10 days of school, okay? So you can create a behavioral indicator monitoring system, just like we did to measure the level, the weekly level of anxiety. You could create one that can measure other things that the parent and or the child thinks is really important and the reasons they're presenting to treatment. Why you might want to think about creating or monitoring other behavioral indicators is it engages the caregiver and the child. To me as a clinician, I think it's important the level of anxiety, okay, to measure that. But if it's important to the child for them to go to school so they don't have to get in trouble, so they don't get called to the office for poor attendance, I want to create a little system and I may monitor that and ask them to pay attention to that. Other examples of things that sometimes we should pay attention and monitor are avoidance of social interactions, or I also would want to look at how many pro-social interactions or activities is the person doing in a week. I may want to look at isolating behaviors or any somatic complaints like stomach aches, headaches, vomiting, that type of thing. And so when you use the PracticeWise system in PEDS, the anxiety results came up with exposure, psychoed for the child and the caregiver, cognitive and relaxation. The last webinar we spoke a lot to the psychoed for the child and the caregiver. And this one is really going to focus on cognitive and relaxation. What we're going to do for the exposure is when we have the face-to-face meetings in November, we're going to be giving some thought and help and guidance and resources at that time during the face-to-face, kind of as a little thank you and reward for coming and participating, because we recognize that getting out of clinic for a half day and traveling to see us isn't an easy thing to do. And another main reason we're doing the exposure as kind of part of the last piece of this quarter is because right now we're about a month into the quarter. You haven't been working with your child enough that you've developed the other skills that he or she needs before exposure would be appropriate. Okay. And there's obviously other practice elements that are listed here: modeling, maintenance, relapse prevention, and all of those we encourage you to utilize the PracticeWise website and look at the practice guides for those to make sure that you're on track and you're following and providing evidence-based practices. So here we go. We have the treatment planner worksheet, and really this is how you conceptualize the case. So Sherry was talking about Allison, and Allison has anxiety and having a difficult time. It sounds like some kind of normal or typical, as I would call it, anxiety or concerns, but then some things that appear to be a little bit concerning. And so if we're looking at the treatment planner and we use the worksheet, that realistically what we're going to be looking at, the beginning, middle, and end phase of treatment, kind of like a map. And so the beginning, as Sherry said, she's working on engagements. She'll be providing some psychoed, teaching Allison and the mother about monitoring and self-monitoring. And then after a while, after the engagement is pretty good and we have a good relationship and Allison and her mother have information related to anxiety, we're really going to start looking at the cognitive anxiety and also relaxation, some problem solving, and exposure as the middle pieces. And then the end of treatment really is the tie-up. And like I like to think about it as kind of tying, you know, I have a birthday present I'm going to give to somebody, and for me the maintenance, the end piece is when I put the bow on it. I've done all of the work, I just am sticking on the bow and the tag. And so I wanted to spend a little bit of time on the practice element of cognitive or cognitive behavior therapy related to anxiety. And this slide, I've had this picture for probably 10 years, and it makes me laugh on a couple of different levels. And the reason I thought it was important is because I think that this is sometimes how we see things. We see somebody, obviously the house or whatever room this is trashed. There's things all over the place. It appears that either somebody's been drawn or taped onto the wall, okay, and the person says, mistakes were made. And so, you know, to me it's like, wow, some other people might look at this picture and think, oh my gosh, what a huge mess, what a huge mess. And this little rabbit's interpretation of this is, yeah, I made some mistakes, kind of, I'll get over it. And so I think it's really important to help clients understand that when we look at a situation, what we think and what we believe impact what we see. And so there's some basic CBT approaches to anxiety from PracticeWise, and really it's about providing education, false versus real alarms, and we talked about that in the first webinar. You know, really you're going to provide some education about how thoughts, feelings, and behaviors are related, and you're going to help understand what are the person's myths about anxiety, and also probably the way the world functions, and really to normalize anxiety, because anxiety happens to everybody, and if we didn't have anxiety, we would be a lot less safe. We're going to teach people as a part of the CBT how to monitor their fear ratings and build on a hierarchy of fear. And we're going to talk about exposure, and then also anxiety management skills. Teach people how to relax. teach people to change the way that they think, and if they start thinking in a way that isn't helpful for them, that may increase their anxiety, teach them skills so they'll be able to change the way they think. And also teach people how to problem solve. And so if we go to the practice element of anxiety, it's really talking about changing one's thoughts and how changing one's thoughts can change the way you feel, okay? And introduce probability overestimation. Now, I love these. The practice elements for me are one of the best parts of the practice-wide system because it tells me exactly what I should be doing to make it an evidence-based practice, to make it more likely it's going to help the client or the individual I'm working with. And then as part of this process is how do you translate this practice element into my practice? And so here we have a representation of what is the cycle of anxiety, okay? So we have some anxiety. We increasingly scan for danger. Physical symptoms intensify. Attention narrows and focuses and shifts to the self. So we kind of have a cognitive narrowing, and we're only starting to pay attention to negative things or things that could go wrong. Then a natural reaction to any sense of fear or harm is escape or avoidance. That's human nature. And so when I escape and avoid, then I feel relief and my anxiety goes down. The only problem is that what I've done now is I've created this circle that when I have anxiety, I narrow my focus and only focus on the anxiety. Then I do some behaviors, and the behaviors seem to take the anxiety away. But it's kind of like a self-fulfilling prophecy. If the only thing I'm paying attention to is negative things, the only thing that seems to be happening around me is negative things. And for me, what makes sense is when we have that kind of thing going on, to teach people how to confront the fear situation without the safer behavior, without the escape, okay? How do we teach somebody how to address an anxiety-provoking situation without using the things that they feel make them safe? And so I think it's really important. I'm thinking right now of an email that I got from a program manager, and she sent it out to the whole clinic because next to one of our clinics, I guess now we have a haunted house, a fun house, okay? And obviously it's only going to be open for a little bit. So I guess there was some weirdness that there was some kind of brouhaha at the haunted house. So what she felt it important to do was to let everybody know, oh my gosh, there's this haunted house, all these bad things happened. And so be careful, maybe we should walk out as a team together. And I read the email and I just thought, like, why would you send that out? Why is that your focus? Because for me, the clinic literally is in the safest city in America, in New York. That if there were a problem and I called the police and called 911, the police would literally be there in less than 2 minutes. Now, that person's choosing to focus on, oh my gosh, there was this one really weird isolated incident. Let's develop all these safety protocols in case it happens again. And how I look at the situation is, that's really weird that happened in the safest city in America. And when I got to the part of the email where she said, because that happened, we should all walk out together at the end of the day, I thought you should walk out together at the end of the day no matter what, because not only do you need to be worried about crime, but to make sure that everybody's out and everybody's taken care of. It just made sense to me. And so that kind of goes to show you how two people might look at the same exact situation very differently. And so if you confront the fear situation without your little safety behaviors or your good luck charms, in the short term, anxiety is going to go up. But what's going to happen is more than likely, nothing's going to happen. You put all that worry into something and it never happens. So the next time you're faced with that situation, your anxiety might go up for a little bit, but it's going to go back down. And then what we've done is we've really given to the client, the adolescent or the child, the power to change his or her life or circumstance instead of rely on something external. So this is the vicious cycle in picture. So your thinking and your feeling and your doing are all connected. And so how you think about an event can change the way you feel, and how you feel will change your behavior, which translates back up into your thinking. And then we kind of created this, and as we have some of these resources, what we were thinking about is it is very different to address anxiety in a 5-year-old versus a 15-year-old. And so, again, this slide would be helpful for an adolescent. However, if you showed and explained this to a 5-year-old, they wouldn't have any idea what you were talking about. And so what we thought would be helpful is to go over the idea of kind of glasses. So the glasses are your beliefs or your thoughts, or the child's beliefs or the thoughts. Okay, if you have somebody who is afraid of dogs, and I'll put my disclosure out there, I'm an animal tolerator. When I was younger, I got bit by a dog, and so then for many years, I hate all dogs. Okay, now I'm an animal tolerator. And so when I was younger, I was probably about 4 when I got bit, and it was a whole thing, and then I had to have stitches, and it was my best friend's dog who bit me. And so I generalized it to that all dogs bite, okay? And so every time I saw a dog, I would panic. And it would literally be to the point I'd be like 10 years old walking with my sister, and I would see like a little chihuahua down the street. I would freak out, and I literally have jumped on my sister's back before to be safe. And so what happened is, because to me, I saw a dog, I knew I wasn't safe, so I totally avoided the dog, or I jumped on a car, my sister's back, a porch, to keep myself away from the dog. I didn't get bit again, and I translated that into all dogs are bad and will bite you. And so what I needed to do to keep myself safe was to get away from them as far as I could. Okay? And by getting away from them as far as I could and as fast as I could, it made me feel safe because I didn't get bit again. And so I kind of had this cycle going that I see a dog, I panic and freak, I do things to protect myself, even though the dog may not have been aggressive, and I was safe. Okay? And so what happens is my beliefs or thoughts that dogs are bad, so I would see a cute little puppy like I have listed here with a pink bow, and I translate that in my head to a ferocious dog. Okay? And so what should happen is a discussion in therapy, if I were in therapy, that, okay, so I understand that you're afraid of dogs. Let's talk about that. How many times have you been bit by a dog? What is your thought process? What do you do? How do you keep yourself safe? And how can you, instead of have the glasses be a huge factor in your life, maybe we can get you to the point that when you see a dog, you still get nervous and you pay attention a little bit more, but I don't have to jump on cars any longer. Okay? And so then, again, this is CBT for somebody who's a little bit older, who can understand a little bit better about the situation, that we can go into depth a little bit more. So this would be for an adolescent. So what you think and do affects the way you feel, and it's a cycle in the situation, okay? And then we have some information. Now, this is not going to be available on the website because this is out of a very good workbook that I think is very helpful for working with children, younger children. And this is information for the parents, and we've given you the name of the workbook as part of our resources. Okay, so now here we go. Safety behaviors over generalization. Sounds real fancy. This is information basically, Homer goes, yep, not a bear in sight here. You know, from The Simpsons, the Bear Patrol is working like a charm. Lisa says, what are you talking about, Dad? Like there aren't any bears here in the neighborhood. And Homer says, of course, it's because of the Bear Patrol. So then she picks up a rock and she says, okay, with that logic, there aren't any lions here because This rock keeps him away. Homer says, how does it work? Lisa says, it doesn't work, it's just a rock. Then Homer replies, but you don't see any tigers around, do you? I want to buy the rock, it must be the rock. So what can happen is he starts to carry that rock around with him all the time. And then he's more worried about tigers when he doesn't have it with him. And so he's always focused on tigers, and he's really overgeneralized the whole situation that it's these lucky pieces, or if I do these things, that will help keep me safe. Okay? And so part of what we do is have people understand that, okay, the adolescent and the child, that these beliefs, it can feel like they keep you safe, but let's look at whether they really keep you safe or not. Because for me, I like to think about anxiety is either what we think, feel, and do can either make our world bigger or smaller. And let me give you an example about that in a few slides. And so here's the cognitive anxiety to stop the practice element, okay? And then it really introduces the idea of thought and how they are related to anxiety, and how we can turn unhealthy or unhelpful thinking patterns into positive coping self-talk, okay? It's all about perspective. And so Alice asked the white rabbit, how long is forever? And the white rabbit says, sometimes just 1 second. So I wanted to talk a little bit about, at this point, one of the adolescents I was working with, she was 11 years old, and what had happened is it started as some general anxiety, then it seemed to go to separation anxiety from her mother, because the mother had had surgery, and it was supposed to be a quick, simple outpatient surgery, but unfortunately there were complications, so the mom had to go back into the hospital, had never been away from the child for an extended period of time. So that kind of seemed to have been the precipitant for the anxiety to develop. And so what happened is they had brought her to see us when she was having a very difficult time going to school. So after I had been talking with her and learning a little bit about her and how she saw things and how things worked according to her and her viewpoint, because that's really important, I was spending a lot of time figuring out how she saw things and how she thought and how she felt and how she reacted. Okay, and so what ended up happening is, so it started out with, first she was just worried about something happened to the mom, and to me, I was like, okay, that totally makes sense. You really had not been separated from mom in your life. She was the youngest child. Mom has surgery. She's supposed to only be gone for an outpatient couple hours. Then you come back. Everything's supposed to go back to normal. That doesn't happen. Mom gets very sick. Mom has to go in the hospital for weeks. Mom almost passes. I'm like, okay, so I see how this is developing. And so I see the separation anxiety, and that makes sense to me, right? And so I'm kind of piecing this together. And then I kind of see how her not wanting to go to school kind of can tie into separation anxiety. I'm like, okay, that makes sense. And then what struck me is what seemed to be happening is her world kept getting smaller and smaller, okay? Because then she really didn't want to go to school because she was worried about mom. And so what happened is if she didn't go to school, mom seemed okay. And so then she didn't want to go to school. Then what happened is she then generalized. She then didn't want to go outside by herself. Now, going outside by herself didn't seem to have any connection to mom or mom being okay. It then translated into she didn't feel safe going outside by herself, and she lived on a farm, and they had like hundreds of acres, and it got to the point that she didn't even feel safe going on her front porch by herself. Okay, and so talking with her and figuring out, hey, listen, do you see what's happening here? Although you not going outside seems to relieve you of your anxiety, now you're not able to go sit outside and read your book, and you used to really love to do that. Let's talk about anxiety and how what you're feeling is normal or typical, and what you might be able to do. So instead of your world getting smaller, can we try to do things so your world gets a little bit bigger? And I'm going to spend a little more time talking about that individual when we really talk about exposure, because we did a lot of really good exposure work with her. And so here we have some unhelpful thinking styles, and this is what I had talked with her a little bit about. So you have mental filter, judgment, mind reading, emotional reasoning, prediction, and then mountains and molehills. And so I really felt that she had a couple of these filters that weren't helpful for her. Mountains and molehills, absolutely. She seemed to really spend a lot of time on that. And so what we ended up doing is finding an alternative thoughts, okay? So this is what we have here. So the prediction, am I thinking that I can predict the future? How likely is it that it will happen? Okay? And so again, really working with her to not only understand the cognitive about how do her thoughts, feelings impact her behaviors and how is the cycle, okay? And what are some things she can do to change the way that happens? So what I'm going to do is I have some more slides here for you, and they're going to be on the website. You can review those at your leisure. But I just wanted to spend the last few minutes really talking about relaxation, because that's another key practice element that we really need to focus on when we're working with a child or an adolescent with anxiety. Okay? A lot of times, so we have, here's our practice guide or the practice element, really helping teach people systematically how do you relax and what makes sense for them to relax. Okay? And here's some relaxation techniques. The deep breathing. I handle the crisis line for Wyoming County, New York, and a lot of times somebody will call me at all hours of the day or night, and they are hyperventilating, hysterical crying, and I can't understand what's going on with them, so I can't help them. The quickest, easiest thing I have them do, the first thing is, what I need you to do, please, is I'm having a difficult time understanding, so I'm explaining why I'm doing this. I want you to breathe in for a count of 4, hold it for a count of 4, then slowly breathe out for a count of 5, and I want you to do that 5 times. Sometimes that one set of instructions is all the person needs. Other times I spend more time, because if I give them the instructions and they continue the hyperventilating, and say, okay, I'm going to count to 3 for you. As I'm counting to 3, please breathe deeply in, and I walk them through it. Then visualization, you're going to work with a picture so the person can have an idea in their head if they're feeling anxious, what helps them relax. There's robot and ragdoll techniques, and we're going to post all of this information for you as a resource on the website. And using helpful self-talk, and really to show ways to help the child relax and ways to help your child learn to relax as well, okay? We have some breathing techniques. A lot of times if you work in an agency, you can't use YouTube, but these are really good relaxation techniques if your adolescent or your child has access to the internet at home, that they could use these. And they're less than 10 minutes, I think. For younger children, that's probably 6 minutes, and for adolescents, it's about 4 minutes. And we have a few minutes for questions and answers, and I apologize, we got started late today due to the technological issues, and so I had to go through some of the slides a little more quickly than I would like. But if you have any questions, if you could do me a favor and put those in the chat box.
Yes, thank you so much, Julie. There was a lot of content to cover, but I think everybody, you were able to provide the summary and the gist for everybody. I think it was also great that there's lots of resources that we were able to find and pull for you. So as Julie had mentioned earlier, The PowerPoint slides, the recording of today's webinar is going to be posted on our CTAC resource page, but also any of those handouts, worksheets, things like that that you saw on the slides, and maybe a couple other ones. If they're not copyrighted, we can post them. We're going to post them on our CTAC resource page. So I just wanted to take a minute to give everybody an opportunity to ask any questions. Please use the chat box on the right-hand side and submit any questions that you have to all panelists. I do have one question, Julie, and I think it's about incorporating parents in treatment, especially if sometimes the work can seem a little bit challenging. How can you go about incorporating parents in this process as well with the child, especially younger children?
For me, I start that at the first session, because I don't think that we can provide treatment or therapy effectively to a child or an adolescent if we don't get the parent buy-in or the caregiver buy-in. And so I talk about that right from the beginning. And so I'll want to know, what does the parent or guardian or caregiver want from treatment? What is their perspective? And what help do they think that they need? And so what I would do is, if I had a 45-minute session, I may spend 30 minutes with the child or adolescent going over some of this, but I'll always bring the parent or caregiver in so they can give me their perspective, and so also so I can teach them some resources and give them some information so they can be helpful, because to me, treatment isn't ongoing. I see people come in when they have symptoms, and then I see my role is to help the caregiver, parent, and child develop the coping skills and the resources they need so that they can successfully complete treatment and go back into the community. And then if they needed to come back for a refresher, to do that instead of offering kind of open-ended therapy or treatment. And I talk with parents and adolescents right from the beginning about that. I think it's really important.
Thank you so much, Julie. We do have a question here that is, are there other shorter scales we can use other than the RCADs? And then how do you score the long version of the RCAD? So I do want to point out that the RCAD has a number of subscales to it as well. So we are recommending the RCADs. However, of course, if you have another anxiety scale that you are using in your clinic, you're welcome to use that one. The RCADs, Julie showed the general anxiety scale, and you can just use that just to have a general feel of anxiety and whether your client is improving or not. You can also pull apart the subscales, as Julia showed in one of her slides, and just do one of those. For example, if they have social phobia, you may just want to do the shorter, it's like 6 or 7 items of the social phobia scale. We will also look at if there's any other ones we can post on the resource page as well as the scoring instruction. So if it's not currently posted, we'll make sure that that's there so that it's clear and straightforward for you as well.
And also I see that somebody has asked, how do you score the RCAD long version? My disclaimer is, I'm terrible at math and I literally count with my fingers. I believe we've given a resource that you plug the numbers in and it scores it for you. If we have not given you that resource, we can make sure that we post it, because to me, I can't figure out T-scales and all that. I just need to put numbers in, and then it has to tell me what it really means. I can count to 18, so that's why I can use the shortened version.
Yeah, but we'll make sure all that information is posted for you so everybody has those as well. We have sort of a comment or a question around parent involvement, and that sometimes a parent can be very anxious themselves, hovering over the child, which also may contribute to child anxiety. So sometimes psychoed, the parent may not see the connection with psychoed. So I'm wondering, I guess moving that process along past the psychoed, how do you keep incorporating the parent so that they are able to kind of see what's going on, since they may also have anxiety themselves?
Great question.
I don't know if you want to expand on that at all. Yeah.
Sure. It's a great question, and I see it often in practice. What I've done in the past is I was working with, she was 16, her mom came in, was very anxious, and Heather, my 16-year-old, was very anxious. And so I was like, okay, you know, how am I going to work this out? And so what I did is I tried to teach the mother the skills so she could help Heather. And then the mother, hopefully a light bulb goes on and clicks in the head that, gee, this relaxation stuff, and that's probably where I would start. In that case, if the parent is also very anxious, I might start at relaxation and helping the mother to help the child identify when they're anxious and when to use the relaxation skills, in hopes she's going to be able to translate that into her own practice. And in terms of the perfectionist, it reminds me of an interaction that I had with Heather and her mother, and the mother had said, she hates school, I just don't understand it. And I looked at the mother, I said, oh, did you love school? Because I'll give you like my take on high school. School was really easy for me grade-wise. I still didn't like to go. I don't know that a lot of people love high school. Did you love high school, Mom? And the mom looked at me like I was really weird, and she goes, no, I hated it. I said, okay, well, I think that's kind of normal then. And so what I did in that case is I kind of normalized and helped the mother understand that Heather's probably never going to love school, and that's okay. Heather just hopefully will get some benefit out of school and not hate going and start going. And so for me, it was kind of helping reframe what the mother, her thought process was, because high school for most people, except maybe 3% who peak in high school, I don't think high school is awesome. But that's just my, you know, viewpoint. And again, it was pretty easy for me grade-wise. I'm pretty kind of typical, really didn't have any kind of, you know, didn't stand out one way or another. And I really didn't love high school at all either. And so I think when you have a parent who's a perfectionist, that you can kind of challenge subtly their thoughts, and then hopefully they'll be able to understand and look at things a little bit differently, because I literally saw a light bulb go off in the mom's head at that point. And was I doing therapy with the mom? No, that really wasn't my intention. My intention was to be able to help the mom help Heather.
Great. Thank you so much, Julie. So as we are wrapping up this webinar, I wanted to point out sort of the next upcoming dates for our learning community. One is Tuesday, October 29th at 11 or at 12. Those are two call-in options for our group check-in calls, and also our in-person training Wednesday, November 13th from 9:30 to 12:30. And for those who are downstate, that'll be here at the McSilver Institute, the same place you had your training. And upstate, I believe it's to be announced in terms of the location. So I just wanted to thank everybody for participating today. Please feel free to reach out to us. Here are all our different emails. Julie's on the bottom left. Feel free to reach out to her directly if you have any questions about any of the content today. Please let us know if for some reason you can't participate in either the check-in call or the in-person meeting. You'll be getting those announcements and those reminders and any type of registration links via email as well. Thank you, everybody, for participating today. If you have any additional questions or any questions that didn't get answered, just email us directly and we'll be happy to help you with anything. Don't forget, again, to check the CTAC resource page for your learning community to download the slides, view recordings, as well as access the different resources we mentioned today. Thank you again, and here are also some of those resources as well. Take care and have a good day.